Today, we are in the latest session of the More Than Just Supplies discussion series. It's hosted by AHRMM, and it's put together by the Young Professional Advisory Committee, otherwise known as the YPAC. So I am one of the new members of the YPAC. I just started this year, and I'll be the moderator for the session. Before we get into our topic and our amazing guest panelists that we have, like any good host, I have to go over some housekeeping things, a few rules, make a few plugs. So bear with me on these before the actual discussion. But I'm excited for today. I've been looking forward to it for a while. I honestly would love to be a game show host in another life. So this is kind of a dream come true, except there's no money at the end of this show. So sorry to all of our panelists for that. But this session was opened up to anyone. And so there might be some people that are not familiar with AHRMM. So if you're not familiar with what AHRMM is, then I encourage you to visit the website at AHRMM.org. And if you're a young professional, then you should also check out the YPAC page on the AHRMM website as well. So one of the YPAC's priorities right now is to engage as many young professionals as possible. And that can mean students, that can mean new grads, all the way to young professionals who are under the age of 35, I believe it is. So sorry to all the 36-year-olds out there, but we had to draw the line somewhere. And so we would love to connect with all of you. And really just our goal is to engage as many young people as possible to try to get them into this wild world of healthcare supply chain that we all know and love. So just so you know, all the lines have been placed on a listen-only mode. And as Anne said, you can engage by typing things into the chat box. And so first thing that I would love for you to type into the chat box is something that would help our panelists get a little bit more of an idea of who's in the audience. When you're doing a webinar and you're not in person, you know, they can't see your faces. They don't necessarily know who you are. So if you could just start out by typing maybe whether you're a provider, which side of the supply chain you work on, provider, vendor, and then your title, our panelists will scroll through that and they can kind of get to know you a little bit better, which would be great. And then there's also a Q&A box that I wanted to mention. We are not going to use that. We have used it in the past, but we figured it's all just best in the chat. And I'll be monitoring the chat throughout the discussion. So if you have a question at any point, feel free to type that into the chat as well. And I will try my best to work it into the discussion and create a good flow for things. If there's 20 questions at once, sorry if I don't get to yours, but you can always email the AHRMM staff to ask questions that we can answer after the webinar. So keep that in mind as well. One more thing on the session. After the session, there will be an evaluation that we send out, a survey. If you could please complete that, that would help us create the best possible webinars for future webinars that we're going to do. So that would be great. Okay, so without further ado, I would like to introduce the speakers. And I'm already forgetting to switch my slides, but I was just really into the intro. So our first panelist is Amanda Chawla, and she is representing the provider perspective of our discussion. And Amanda has over 20 years of healthcare leadership experience, and she has led both clinical and non-clinical teams. So she's presently serving as the Chief Supply Chain Officer at Stanford Medicine. And personally, I saw Amanda speak twice at last year's AHRMM conference, and she has a really unique way of inspiring you, challenging you, and making you feel great about yourself all at the same time. So I'm excited to have her on the panel today. Thank you, Amanda. Our next panelist is Robin Lincoln. So Robin is representing the GPO perspective for this discussion. She is the Chief Contracting Officer at Capstone Health Alliance, which is based in Asheville, and it was named the largest regional alliance in the country. So pretty big deal. Robin is a negotiator, she's an implementer, and she leads not just the contracting team, but she also leads several different supply chain councils within Capstone Alliance. And get this, she is also leading the business intelligence team. So talk about future of supply chain right there. That's pretty awesome. And then last but not least, we have Peter Saviola. Peter is our third panelist representing the manufacturer/distributor side of the discussion. And Peter has busted his butt in both the boardrooms and in the field on the ground floor of things, which I appreciate since I'm also based at a site and I know that life very well, at least at the hospital level. And so Peter is, in the past, has run a couple of Medline's biggest distribution centers, and now he's actually leading their supply chain optimization team. So that is our panel. And very quickly, short agenda here, but I wanted to go over the agenda. We'll start with some learning objectives next, and then I'll actually give a short introduction to the topic. Just a quick little anecdote that I think kicks off the discussion pretty well. And then we'll start with some questions that our very own YPAC members came up with and wanted to ask these folks. And then, as I said, you can still type in questions as we go, and I'll try to field them or direct them. And then at the end, we will save some time for a Q&A at the end if you have questions at the end as well. Sound good? Okay, so learning objectives. Today, we want to learn about how these organizations that these folks work in are disrupting traditional norms when it relates to inventory management. We're also going to learn about some practices for forecasting critical supplies and demand planning and maintaining operations. And then last but not least, we want to just understand the vision of what the future of inventory management looks like. So, last thing before we start talking to our panelists is I just wanted to give a quick intro. So we have titled our discussion, The Future of Healthcare Supply Chain, How Organizations Are Proactively Managing Their Inventory Using Demand Planning, which is a bit of a mouthful, but what did you expect from the Association of Healthcare Resources and Materials Management? So all jokes aside, inventory management is such an important topic right now and has always been, and it's really at the heart of what we do in supply chain. So we want in this discussion to go beyond just the focus of demand planning and forecasting and different methodologies and stuff like that. We really want to talk big picture in this discussion and focus on solutions that these folks are working on right now and the long-term big picture things that they are doing in their organizations. So just this week, I was telling a new colleague about how during the pandemic, Centura Health was making its own isolation gowns in a conference room, basically. And he, not being a supply chain person at all, was asking all these great questions that he was asking. So when do I expect things to get better? And are things bad because of raw material shortages? Are they bad because of labor, or is it just COVID? And I was my brain was bouncing back and forth on all these things. And really what it came down to is that there are so many different complex issues that we are facing today in our worldwide supply chain that we've created. And I don't know when things will be better, and I certainly don't want us as an industry to go back to the old ways. But I do know that there are very smart people like Robin, Peter, and Amanda who are working on solutions every single day and making things better every single day. And today's discussion is really about creating a better future and what these leaders are thinking about what it looks like. So that is my intro. We'll now move into our panel discussion. And I'll kick us off with some of the questions that the YPAC came up with. Okay. All right. First question is for you, Robin. Can we hear you, Robin?
I'm here.
Great. How are you doing today?
I'm well, thank you, Derek. How are you?
I'm doing pretty well, hopefully. So Robin, I read a little bit about you, and it seems that you love to focus on these complex problems and creating long-term plans and solutions for them. So I was hoping you could just start off by sharing what are some of the long-term projects that your teams are working on, and how can they help with supply chain planning?
Okay, great. Thank you, Derek. And again, thank you for the great introduction. I appreciate that. Welcome, everyone. Kudos to you for spending your Friday afternoon really, learning from others, and you're going to be, if you're not already, the future contributors to this profession that we all share and enjoy and work to make better each and every day. So congratulations to you, and I'm pleased to be here with you. So as Derek mentioned, Capstone is a regional GPO. We have 145 health systems. This is not going to be a Capstone commercial. I just want to kind of give a little bit of context to where my comments are coming from. I'm in I consider it enviable position of facilitating discussions on a very regular basis with some very impressive supply chain leaders. And I learned from them, and I learned from the suppliers each and every day for the 15 years that I've been doing this. So a lot of what I'm sharing with you is for our younger audience. I don't know if you ever saw a Reader's Digest book of short stories in your grandmother's closet, but these are stories that I am hearing from our supply chain leaders on each and every day. So we really try to keep it real, as opposed to conceptually, how should things be working. What I'm sharing with you is what are people actually doing in our 145 health systems. So in terms of demand planning, we do have some people on the panel that have much more expertise than I in terms of inventory management. So my opening comments are really focused around labor. I actually just returned from a distribution conference, and there was an entire session that was dedicated to employee retention, especially following the Great Resignation. I'm sure you all see it on a regular basis when you go to your favorite restaurant and they close at 8 o'clock and everybody's struggling with it. And I think especially in healthcare, there's a lot of opportunity for education out in the labor market, that there are some great healthcare jobs that don't require clinical training. But some of the comments, that I wanted to share is really, again, I have great respect for the supply chain leaders with whom I've been working. And to me, I'm always impressed with the amount of clinical knowledge that they have, so that they can have those in-depth conversations with their supplier partners that come in, but also keeping an eye on the financial perspective. So, anything they do cannot be single dimensional. It has to take so many different variables into consideration. So, I think throughout their years, they probably started focused on something very specific, and it might have been inventory management, but expanding into those other areas of the hospital and just becoming that comprehensive leader and understanding all aspects of the healthcare system. So I would just say what I'm seeing a lot of our hospitals doing right now is thinking about continuous improvement for the workforce. So giving the team stories to carry home about the importance of your jobs in terms of, patient care, and that you are a vital part, regardless of where you are in the hospital, of providing good patient care and making sure everyone has what they need. Giving positive press to healthcare non-clinical positions, very important, and small promotions and recognition at shorter intervals. So in terms of the long-term projects, I know, Derek, you're wondering if I'm ever going to circle back to your question. Some of the long-term projects we see our hospitals focusing on, and actually it was just in the past 2 days, I've seen what might seem like the areas where there are best practices. There's still so many different ways, I hate to use this analogy, but to skin a cat. So inventory management right now, we're seeing that maybe a fourth of our members are using Pyxis, a fourth are using Omnicell, a fourth are using Tumid Kanban, and others are just doing their own, homegrown management methods. So really trying to tie everyone together and sharing those best practices has been a big focus for Capstone outside of the contracting piece. The EHS or EHR systems, MMIS systems, we're seeing a lot of transitions and new programs or systems like Workday, and a lot of those decisions aren't really being driven by supply chain. So how did those leaders be best prepared for that day of transition to the new systems when everything changes in their worlds? And then, of course, PPI is, always there on the forefront with the majority of the spend. And how are our hospitals involving physicians in the value analysis process, in the reimbursement discussions, in reporting, but again, mainly in how do you improve outcomes and tie it all back to product. So there are a lot of different examples, and I know we'll have other opportunities to share on that, but I think for now that's probably all I'll share on the opening comments. So I'll put it back to you, Derek.
Great, thank you. Yeah, I mean, all of the work that you just mentioned, I think is helping providers and suppliers tremendously. So thanks. Wanted to ask Amanda our next question. And Amanda, I know that a lot of the leadership that you pride yourself in is very much relationship-based focused, and you love how supply chain gets to touch all the different aspects of the entire healthcare system. So I'm curious that which relationships do you think have been really valuable lately in helping with inventory management? And which relationships do you think in the future you want to focus a little bit more on?
First of all, thank you to yourself and the YPAC committee for having me. It's a privilege to be here and spend Friday afternoon with a number of you. Let me just get started. My team probably gets really tired of me saying this, but we are in a business. Healthcare is a business, but it is a people business. It's all about the people. It's all about partnership. It's about communication. It's about how we work together. And so before I dive into the inventory component, one of the most important relationships is with our teams. I want to start internal. Having a strong relationship with your team members and within your own organization to the front line is paramount. If we're not aligned on our goals, our objectives, our challenges, and how we intersect and how we work together, it's really hard to do the work that we're trying to do and have the impact that we are trying to have in supply chain more broadly. And so to me, that piece is huge. As I think about this, we get hit with how many pieces of communication a day between our emails, our social media, TikTok, Facebook, you name it, LinkedIn. There's so much information coming at us. And then we're also going out there trying to develop relationships, retain relationships, but also providing key critical information. And so when we're talking about relationships, communication goes hand in hand. I do want to stress that piece. When I think about relationships a little bit more broadly, ultimately, what's our role in supply chain? Our role in supply chain is to provide to the healing hands that care for the patient. Ultimately, we're here for that patient. And so when you start thinking about relationships, really the next level of relationships is all of our providers. It's the healing hands. It's our physicians, our nurses, infection control, environmental health, pharmacy, your lab scientists, you name it. It's every facet of the organization organization. And if anything, COVID has taught us and shown us and proven to us the reliability of the supply chain. The partnership is really dependent between that clinical partnership. We wouldn't have been able to pivot to the innovative solutions that you heard Robin talk about, or even Derek mention, had it not been for the strong clinical relationships. So to me, that piece is critical. The other aspect of relationships is strong executive relationships. My job as the chief supply chain executive is to be the biggest cheerleader for supply chain, both internally for the team and with our executives, and more broadly. It's to represent, it's to engage, it's to obtain feedback and provide feedback. And relationships can occur in a number of different ways. They can be designed to be very intentional as well as unintentional. And what I mean by that is, at least for my teams, we have informal dyad partners. We look at the clinical supply chain and we say, okay, once a quarter, we're going to meet with this person. It may be a quick 15 phone call. How are you doing? How's everything going? And a check-in, but it develops trust. And that really leads me into kind of the inventory management and the inventory response. In order for us to be talking about demand forecasting and inventory, we've got to understand our customers. We've got to understand the utilization practices. We've got to understand when clinical practice changes or volumes changes, how that impacts our inventory. So that's another way in which relationships intersect. And then look at this group here. Many of you guys responded to Derek's question in the chat. You're forming relationships with each other. There's relationships within the industry, relationships between myself and my colleagues in the industry, and then there's the relationship with our suppliers. And I think that's the area, to the second part of your question, Derek, that I want to go into, is we need to continue to develop stronger relationships with our GPOs and our suppliers. This is an ongoing challenge. And one of the reasons for that challenge is really the navigation. If you think about your own organization, navigating your own organization can be complex because you're sometimes not sure who to go to, who has what responsibilities. But now when you're thinking about it from a supply chain, or really a supply network standpoint, our broad environment becomes even larger. And so knowing who to work with, how to work with the different suppliers and the GPOs is critical. This last component that I'll end with is where we have opportunity is really around this conversation of transparency and building trust. We've got to come together as a supply network to be able to effectively manage inventory, to be able to effectively do demand forecasting and demand planning.
Great answer. Thank you, Amanda. Yeah, and transparency within the relationships, within your data, within your own team, and being that cheerleader is very important. So thanks for adding all that. Next question I wanted to pose to Peter. So, Peter, how are you today?
Pretty good, Derek. How you doing?
Thanks for being here. Appreciate it. We wanted to start off with a question for you, Peter, about Medline and really about Medline's way of thinking about the future. So the question is, how does Medline make the long-term plans for their inventory strategies, looking in years into the future, as opposed to just the here and now?
Sure. So there's a lot in that question. So let me just back up a second and say thank you again also for inviting us, and thank you to the YPAC group, of those of you that are members and those of you that are considering membership. And I noticed from what's scrolling past me on the chat here, some of you are not young professionals. I'm certainly not at that point in my career either. But participating in these types of events is throughout my career, certainly at 20 plus years, has always been extremely helpful. It's just the relationships you build, the information you collect, and just the knowledge sharing just expands your ability to support everything that we want to do collectively in healthcare and just try to make things better, right? So thank you for spending your Friday afternoon, and selfishly, thank you for letting me take a 60-minute vacation from all the other Medline stuff I have going on a Friday afternoon. So a little bit of probably more pleasant for me than it is for you, but thanks anyway. So getting to your question, Derek. So Medline, and you introduced the organization pretty well. We're both a manufacturer and a distributor. It's a little bit unique. I guess at our core, we're a manufacturer that always had the infrastructure to become a distributor. And about 15, 20 years ago, we chose a path of becoming a distributor because we felt we could influence and drive value better if we did things that were in the best interest of our customers, our company, and our employees. Those are kind of the three fundamentals we always keep in mind. If we can control those, we could provide better and more consistent outcomes. There's a fundamental philosophy there. Along with that, sort of as a manufacturer, you sort of at your core always have these longer range visions, right? So in simple speak, we've all been to business school. If you make more, it's less per unit because you made more, right? So there's these longer run, longer vision. So we apply that same philosophy to the way that we manage our business and the way that we manage our inventory. So, and there's some fundamental business reasons we're not a publicly traded company. We don't have quarterly earnings. I came here from a publicly traded company and we don't have budgets. So, and I thought, oh, we don't have budgets. This is going to be the greatest thing in the world because I used to spend 6 months building a budget and 6 months defending a budget. And then, it was never right. But it's the worst thing in the world. And it's sort of like a budget was always a benchmark of success. You hit your budget, everybody leaves you alone. At Medline, there's no budget. So the measure of success is do better than you did yesterday at everything you do. Okay. So in order to fundamentally do those types of things throughout our business, we have a longer range horizon of this constantly incremental improvement. Okay. We have a saying here, don't let great get in the way of good. And so if I could just make things gooder, maybe it's not great, but it's gooder than it was yesterday, then that's what we should do. So what all that gets to is this philosophy of when we look at inventory. Okay. We went down this path years and years ago. And again, it comes from a manufacturing background. If we hold more, we'll have a better fill rate to our customer. We'll have a slightly higher service level. We'll be able to buffer disruptions in supply chain. So we deploy that type of a methodology to our inventory. Now, it's not always right. It's not always great. And certainly during the pandemic, you can't even get the supplies, right? But where we're able to and where we have ability to, we try to go a little longer. We think it downstream helps with avoiding disruption. Obviously, providers on this call do this all day long, right? You either sub an item or you alternate source an item. And while that still gets you the item, the cost, the disruption, the hiccups in your supply chain, they're costly, right? And those costs certainly far exceed the cost of just holding some more inventory. So there's a fundamental core of how we operate and what we do that's a path we chose to take is just have more. We think it helps us buffer hiccups, interruptions a little bit better. Obviously, not always. And then where we can, and to put it in more recent terms, as we're coming through the pandemic and we're seeing what used to be short supply and unavailability of masks and isolation gowns, right? At the start of the pandemic, those are all recovered. But now we're seeing these rolling back orders as supply disruption across the globe starts to settle in. And you're hearing things about container ships and lack of, what's happened in the supply chain is the pieces of the physical pieces of supply chain, because of a massive interruption, have now become out of balance. So there's empty containers in all the wrong spot. There's ships backlogged at the port, more so than the chassis can offload those ships. So you have these out of balances in supply chain, and what that's causing, that bleeds back across the globe. It's causing hiccups in product disruption of a product is short supply this week. It might be in great supply next week, okay, or 3 weeks down the road. So you're seeing these, what we call rolling back orders. It's not always the same item, but it's still interrupting the total supply chain for the industry. We're trying to go long where you can go long and then hold that inventory, because we're sort of betting that 3 weeks down the road, that item we're long on might be disrupted in the supply chain. And our hope is that then we have enough to buffer that and kind of keep doing that until what we think will be a 2023 mid to third quarter normalization of supply chain.
Awesome. Thank you, Peter. Appreciate the answer. I know Medline is known for having some of the biggest warehouses, so that definitely helps you hold more inventory. So speaking of holding more inventory and going longer, one of the things that when I thought of the future of healthcare supply chain, the YPAC and I thought back to Dr. Bradley's presentation at the last conference. Since I saw you twice there, Amanda, I'm hoping you saw his talk as well, because I wanted to ask a question about what he was talking about. And for those of you who weren't there, just a quick recap. One of the things about the future that Dr. Bradley mentioned was a shift away from the just-in-time inventory model and kind of finding more of a balance with what he called just enough. So I wanted to pose the question to you, Amanda. What does just enough inventory mean to you?
So Derek, I think this is probably one of the hottest topics right now in industry, and just enough is the next buzzword here. I actually just finished writing a perspectives piece on this very topic that should be coming out soon in the Supply Chain Strategies and Solutions magazine. But to break it down in very simple terms, it's what I call a balance between, or it's what I call essentially just right. It's really the balance between just in time and stockpiling. And no, it's not just in case. And I think it's really, really important that we don't move the pendulum away from just in time to just in case, just because of the experiences that we've had over the past couple of years and the current experiences that we have. It's important that we have to learn and operate differently. And so just right really means to forecast, to produce, to adjust, and to manage to the inventory that's needed to the bin where the healing hands are. It's not only about what's in our asset accounts or what's in our stockpiling warehouses or what's at our distributor. It's about what's needed at that bin. And that's why I'm kind of using the word just right, because it's the inventory flow to that bin. It's to build a structure, process, and flow. And so at Stanford, we are designing and piloting for hospitals that are like Stanford, where we're reliant on just in time. We're not large enough where I would suggest to our organization we should open up our own consolidated service center. But the reality is we have opened up a warehouse. We have stockpiling of inventory occurring. We need to do that today because 20% plus of our orders are not coming in on a daily basis. And it is not an acceptable answer to our clinicians to say, I'm sorry, 20% of our orders didn't come in. You don't have what you need to provide that patient care. And so that 20% is what I'm talking about, is that just right. And what that's about is essentially creating a function within your supply chain organization that has that ability to forecast and has that ability to pivot. The best analogy that I've come up with to use here is really think about traffic control and the traffic control tower that's used. A lot of what we learn in healthcare comes from the airline industry from a safety standpoint. Why can't we apply that type of thinking into the way that we're managing our own inventory? So just right, at least the way that we've defined it, is taking that just in time, taking that stockpiling, meshing it together, taking the disruptions and the forecasts that are occurring daily and pivoting so that bin at the end of the day is not experiencing shortages. That's really the idea.
Great. Thank you, Amanda. Robin, Peter, any thoughts on that question or Amanda's response?
Yeah. I mean, if you don't, I'll be happy to jump in. Yeah, I think Amanda's right on. I think here, this is where a lot of the topics or the questions you've already asked sort of begin to mesh or blend together, right? It's all about this. How do we together collectively share the data and create a better horizon of visibility, right? So if Amanda knew what I had in my distribution center, not only what was there, but what was also what was and what was not coming into that distribution center, and took that information matched it to what she had on the bin and what she had in her stockpile, that would provide this, in her words, this tower of visibility, right? A broader horizon across the supply chain. And we agree with that. We agree. So from Amanda's side of the fence, that allows her to pivot and pre-position and plan better and communicate that planning to those healing hands, to those clinicians in advance to minimize disruption, to provide smoother, more consistent care. From our side of the fence, then we are also in a better position as they pivot from item A to item B because it works just as well. Then we're able to adjust in a more synchronized way with what the usage is at the front end. We could adjust the back end in more harmony, where today, in today's good old-fashioned supply chain, providers do one thing, distributors react, okay? Providers do something else, distributors wait, then they react. If we could harmonize that communication, be more transparent, right? Be on the same page, collaborate better. And it's not one or the other, it's just the way we operate, right? So if we could bring those together, we think that provides a much more consistent flow. Everything that Amanda's talking about are sort of like, these are the lessons we're learning from the pandemic. And I'll add one other thing. There is another sort of learning, I think that's coming out of this. And a lot of what we did in how we were driven in supply chain was around a term called clinical preference. And that's really good. Clinical preference does matter, okay? But there's also a term called clinical acceptability. So I think when you look at the global supply chain, and I think, who knows, but we might be coming to a point where we're going to have to just realize that there's probably always going to be some form of disruption. And the best way to become a more resilient supply chain in total is to provide more alternatives to buffer that disruption. And that will become this choice of clinically acceptable items. Yes, there's always a clinically preferred, but there's this bandwidth of clinically acceptability. And we have to learn how to move to that bandwidth of clinically acceptability to, in simple speak, we need to fill to the bin, okay? Regardless of the acceptable item, we need to get it to the bin. Obviously, you want the preferred item. And then how do we communicate and pivot, in synchronization with the provider, the distributor, the manufacturer, and data in transparency is going to help us do those things.
Peter, I
Thanks,
think
Peter.
that was well said. I'm going to add one additional thing, and that is the patient perspective here. And when we talked about data, we talked about syncing the hospital data, the distributor data, the direct supplier data, the clinical equivalent data, but there's also the utilization data. There's the understanding of the clinical practice. So it's bringing all of those things under an umbrella so you can pivot your inventory management techniques from these different sources and be able to serve.
Thanks, Amanda. So we have a question in the chat from Rachel from our YPAC, and it's directed towards Peter. However, I'm going to ask it to Robin after Peter as well. So Peter, we'll start with you. How are you seeing customers pivot from item A to item B smoothly? Is this something that the distributor is helping us as providers to identify? That is a big challenge for us.
Well, you're not alone. Okay, so the fact that you're considering doing it puts you probably, in the top tier of the class. So, but it's not easy. I think there's, we've always talked about this whole pre-pandemic, people would always, we'll have a pre-approved sub list, and we'll go create this pre-approved sub list, and somebody through Value Analysis will vet it and everything else. And while I think that was suitable, I don't think anybody really chose to dynamically manage that type of a process, right? And I think the differences today but this is not a Medline thing. They're all good distributors that are out there today. They're all smart. There's really good systems available to all of us. So any distributor partner, and any sourcing team can identify what those, or help identify the ABC, the tree of clinically acceptable alternatives, and present those and keep those sort of targeted. One of the things that we specifically have learned is to build a auto subroutine. Now there's a lot to that because you have the pay to procure cycle. So I ordered item A, but I got item B, and item A has one price and item B has a different price. So you still got to reconcile and make that payment. But there are transaction sets today that allow those things to happen. So again, in order to do that, a lot of the key falls to really what Amanda and Robin's opening statements were about transparency, right? So it's all about communicating with your partners, being transparent about if you don't have item A, you have item B. I understand item A costs one thing, item B costs something different, higher or lower, right? And I think some of this is going to sound, I don't mean this to sound unpleasant, but in the past, and I've been around long enough, a lot of those conversations would end with, well, I buy item A at $10 and item B is $10.50. You're going to give me item B for $10, right? And everybody, the distributor, the manufacturer, everybody at that point begins to cringe. You know, all the alligator arms come out at the table and nobody wants to move the conversation forward. But I think we're beyond that today. I think that's one of the things from the pandemic is the pain was so bad that everybody's beyond that and realizes that, look, if there's different pricing, we're going to work with GPOs to get multi-sourced agreements that allow for a more homogeneous price for a category of single group of items. So it's starting to move in that methodology. So it's sort of all those things together of, you know, the GPO's got to be in line with helping multi-source items that can be. So you get consistency of price, right? You have to get value analysis to get consistency of, you know, clinical outcomes on those items. And then a distributor that can help you build that portfolio and automate those processes. And that's, in short, that's what we do today is we have an automated process that we've begun to deploy where if you don't get the preferred item, we have a treed sub list and an auto pull from those. And even if that's from the healthcare provider stockpile, we can do as well.
Great, thanks, Peter, and thanks for the question, Rachel. That fit right in. I did want to remind everyone that we will save about 10 minutes at the end to answer any questions in the chat. So if you have them, please post them now, and we'll get to them in just a little bit. So, Robin, I'm curious as to what the GPOs are thinking as far as the future of, you know, the maybe not the auto subbing like Peter mentioned, but the vendor diversification piece of this just-in-time or just enough inventory. So what are GPOs doing? I know they've done a lot during the pandemic, but what are GPOs doing to help providers and suppliers with vendor diversification?
Yeah, clearly that's been a big issue for everyone, Derek. I don't think there's anybody on this call that hasn't been involved in that process in some form or fashion. I think it's safe to say that all GPOs and really most providers spent really an inordinate amount of time vetting alternative supply sources during the past 2 years. So this, in a lot of cases, proved to be a lot like looking for the pearl in the oyster bed. And there were a lot of cuts and scrapes along the way, whether it was, you know, exorbitant prices or just products that weren't meeting the quality specifications. And we saw even reputable suppliers who attempted to get into the PPE market just to help. And they wound up really getting a damaged reputation because of manufacturers who misrepresented and couldn't deliver. And I wish I could see faces, you know, the participants, see how many people are saying, yes, we were part of that process. So, you know, I think what we have seen is that, you know, one point is what Peter was talking about earlier, some type of global cross-referencing vetted resource that hospitals could share, because there's been a lot of replication of efforts along the way. So traditionally, I think we all recognize that most health systems weren't willing to accept another health system's value analysis results on substitute products. We saw a lot more acceptance to that during the past, 18 months, 2 years, that if they, and I think especially in a situation where if you're a health system and you work closely with others in some type of collaborative group, something like AHRMM, you've gotten to know them, you know what their quality standards are, you're probably a lot more likely to be accepting of somebody else's, cross-reference when it comes to alternative products. So, I think right now, and this is just a little bit of a tangent, but I've seen our members get so frustrated when still to this day on national conferences, the suggestion is made to go ahead and develop a list of alternative products. And we're seeing our members go, we've already made it through levels 1, 2, and 3 of the alternative products, and we still cannot get what we need in order to handle the patients. So again, that was just a little off side, but the national database of vetted cross-references would at least be a starting point, understanding that most health systems would need to take it a step further. A global reporting mechanism for the unreputable manufacturers, if that exists, I'm not aware of it, and I don't think most of our members were, but we saw a lot of people getting into the same, situation of, buying product either at exorbitant prices or just not meeting the quality standards. We had one member who he actually did find a container of gloves. They were acceptable. The container arrived non-palletized. So that was a little bit of a surprise on a Friday afternoon. But anyway, a central reporting system for that, I think, would be very advantageous. And again, I just got back from a conference, and the indications I heard from an epidemiologist were that I guess when we got into COVID, I thought, how likely is it that we'll be in the same scenario in a couple of years? It sounds like it's possible, the way the population growth has gone and just a number of factors. So I think there are things that we need to plan differently going forward. And, I know Amanda talked about it earlier. The communication piece is key. And so we still, to this day, have hospitals that really aren't aware that a supply is not available until the day they're expecting it to show up at the dock, and then it doesn't come. So it needs to be timely, it needs to be relevant. The communication piece of all times in our life cycle, at least certainly mine, we have more means of giving real-time, accurate communication, and I think we just have to develop some standards that everyone participates in.
Great. Thanks, Robin. We have another question from Mike Schiller in the chat, and he's asking who is conducting tier analysis of their suppliers and how/who are you working with? So I'll pose that to Robin.
Yeah, and by the tier analysis, I guess I kind of go back to the fact that we do have a business intelligence team, and we have access to all of our members' data. We keep it blinded between the hospitals, but we are able to look at the data, and especially the contracted tiers through the national GPO. So the tier analysis, again, is done internally for us. And for those of you that are in a situation, if you're not doing any kind of specific tier analysis, my only suggestion, and I'm kind of watching the clock for you, Derek, is that make sure it is done using weighted analysis based on your own utilization, because I have a lot of conversations with suppliers around pricing discipline, and I don't think it's uncommon, and I don't mean this to be a slam on any suppliers, but it's not uncommon for there not to be much of a pricing discipline, that there's a lot of adapting to the situation, what that health system needs, what they need in terms of meeting quotas. So what we frequently see is that if you have 4 tiers, there might be different margins on products across all tiers. So there could be loss leaders at a tier 2, and tier 4 looks completely different. So I would just say investing in that analysis definitely helps when you get down to the negotiation piece, so that you don't have any unanticipated surprises.
Great. Thanks, Robin. There's another aspect or another type of tier analysis that I think of when I hear the term, and that's more talking about looking at your suppliers and who are their suppliers, and do they have one supplier or two supplier for their suppliers? I would love to hear what Peter and Amanda's thoughts are on, or if they're using that.
I'm sorry, Derek, can you clarify what the question was? I missed it.
So Mike's question was, who is conducting tier analysis of their suppliers? And Robin talked about some of the pricing tiers.
Right.
But when I think tier analysis, I think about looking at your suppliers and how many suppliers they're working with.
Exactly. Yep, that's how we're doing it.
And so would you mind talking about how you're working on that and what your solutions are for the future?
Yeah, so we have probably 3 or 4 different strategies going on at the same time. One strategy is definitely partnering with external agencies, and there's a couple out there and/or initiatives really doing the supplier mapping. There is supplier mapping out there, so we can learn the dependency. The second component of that is understanding the forecast of where those disruptions are occurring and being able to map it up to the products that we're utilizing. That's probably one of the biggest strategies that we're doing. The second component is we are looking into, and I do see a question here about AI and automation, but we're looking at certain technologies that can provide us intel on disruptions with suppliers. So that would then feed into essentially our tier analysis. And then the third component, is really around our sourcing strategies. And when we're going to market, when we're doing RFPs, that we're requiring certain levels of information, we're changing on contractual languages, and we're building it into our overall strategy. So like I said, there's like 3 or 4 different things that we're doing, all which I could go further into detail for.
Great. Thanks, Amanda. We have about 6 minutes left, so not too much time to get into any lengthy questions. But since you mentioned AI, and there is a question on that, I wanted to ask Peter, just in a little short answer, when you think AI and automation, what do you think of when it comes to Medline?
So, well, we're trying to use AI. We started using AI in our inventory management and planning departments. So we're using it to help better predict utilization and usage and demand disruption. Our goal is to use AI more, and where we see it helping us is more on our import manufacturing side, where we can use AI to better predict steamship lines, their vessel drayage and detentions. A lot happens to a ship out in the ocean, right? It isn't just a quiet journey of X number of days. Storms and port disruptions can delay it or can reroute it, which we've done. So we're trying to use AI more upstream in the supply chain, not only once material leaves a manufacturing site, but also within those manufacturing sites. We see the ability to use AI to help us source raw material better from multiple sources, more so than we can do today, right? So there's a lot of vetting, as you can imagine. There's a lot of vetting that has to go into country of origin, site selection, and quote manufacturing plants. There's a lot of vetting that has to go into the raw material sourcing that feeds that plant. So all of that, we see AI being able to enhance that process for us. But it's newer. Today, the most prevalent deployment of AI right now for us is in inventory management, because we have the best amount of predictable outcomes, if you will, right? In that environment, like we know what to expect already. So we know if AI is really helping us or if we just dumb luck got better. So, and where I think AI will help us in the future a lot more is what we talked about previously with Amanda, getting that provider data. This is way out there, but if there's census coming in, right? There's patient admissions. there's some degree of predictability of why that patient was admitted, not who they are, but why they're coming in. And based on that condition, there's a length of stay, there's a surgical schedule, all those things, can you predict them? Can you pre-deploy and pre-plan inventory for those needs, right? So that's ultimately where we think AI will ultimately go.
Thanks, Peter. I don't see any more questions in the group that we could answer in the next 2 or 3 minutes. Any closing thoughts from Robin, Amanda, Peter?
I would say a lot of, our discussion has really been on the technology, the transparency, the communication, and the process. And it's all of these things together. It's the investment in them. It's the need to reevaluate, rethink how you're operating, how you're leading your business. And the best piece of advice I think I would leave you with is this concept that supply chain is not a linear chain. It's a supply network. And the way that we work has to be different. It needs to continue to transform. There's a lot of opportunities. I think we all struggle and we're all frustrated with the disruptions in the markets or the whack-a-moles or the firefighting, but we've got to bring a sense of calmness in that approach. We've got to bring a sense of structure, and it's up to us as leaders to be able to step back and take a look at the big picture and to be able to partner on things of this sort.
Yeah, and I'd just like to add to what Amanda just said, and we're a big fan of Dr. Bradley's as well. And he has spoken at several conferences that I was attending, and he said supply chain acted exactly as it was intended to at the beginning of the pandemic. So it is all about kind of rethinking the new world. This is going to probably continue for at least the near future, and who knows beyond then. So it's an opportunity just to rethink strategies. A lot of emphasis on global relationships and the communication piece between health systems. I think more now than ever, putting aside the competitive aspect of that and sharing best practices and working together to really streamline and take care of the patients as best we can.
I'll just close out by comments with, I think Amanda and Robin are right. There's been a lot of talk today about technology and AI and advanced processes, but both Amanda and Robin mentioned something that we can't lose sight of. All of this, the source of all this is communication. It all comes down to communication. So being the older guy here at Medline that works with a lot of younger folks that like to Teams me and text me and everything else, and get on these email chains, and we get wrapped up in the technology and trying to move the needle with technology. But you know what always works? Always works. The telephone still works today. So don't forget, it comes down to pick up the phone, speak human to human, and you probably get a lot more things done a lot faster.
Thanks, Peter. I think, yep, totally right about that. Well, everyone, this is our time. Thank you very much for joining us. To the audience, Amanda, Robin, Peter, you all have been wonderful. The YPAC's goal is to try to get the young people into the industry, right? And to keep them around. So even though they might be texting, we still want their talent. I think today was great, and hopefully got some people excited to jump in. So thanks, everyone. We are all out of time.